My name is Dr. Isa Al-Dafiri. I am consultant adult endocrinology from Riyadh. It gives me great pleasure tonight to introduce Dr. Francis Hayes, who is Associate Clinical Chief of Endocrinology at Mass General Hospital, Associate Professor of Medicine, Harvard Medical School in the US. Dr. Francis is the Associate Clinical Chief of Endocrinology at Mass General Hospital, Boston, and Associate Professor of Medicine at Harvard Medical School, and a Fellow of the Royal College of Physicians of Ireland. She attended medical school at University College at Dublin, Ireland, and completed her residency in internal medicine and fellowship in endocrinology there. Her clinical and research interests include male hypogonadism, a topic on which she has lectured and published widely, as well as Turner syndrome, for which she is a co-director of the clinical at Mass General Hospitals. Dr. Francis will talk to us tonight on her expertise in male hypogonadism. Dr. Hayes.
Terrific. It's a real pleasure to join you this evening, and greetings from Boston. So I'm going to talk about certain aspects of male hypogonadism in the next 30 minutes, beginning just with a basic definition so we're all clear about what we're talking about. And the definition that I use was the one put forward by the Endocrine Society Clinical Practice Guidelines, namely a clinical syndrome resulting from failure of the testes to produce physiologic levels of testosterone due to disruption of one or more levels of the hypothalamic pituitary gonadal axis.
Yeah, tamam.
So you should be all very familiar with the classification that I'm not going to go through in any great detail, but just to briefly describe the defect in primary hypogonadism is in the testis, so there's a compensatory increase in gonadotropins, and it can be congenital or acquired. And in the past, we thought of this as a cause of sterility, but increasingly now we are able to extract sperm from the testis through advances in andrology, microdissection testicular sperm extraction, so that sterility is no longer an inevitable part of primary gonadal failure. I wanted to focus just a little bit on Klinefelter syndrome for a number of reasons. It's very common. It's got an incidence of about 1 in 500. And the other important issue is that in addition to hypogonadism, the presence of that second X chromosome is associated with multiple extragonadal features, including a metabolic profile, metabolic syndrome and type 2 diabetes, an increased risk of certain malignancies, including extragonadal germ cell tumors and breast cancer, and then importantly, some learning challenges, ADHD, and an increased risk of depression and anxiety. Secondary causes then can be congenital or acquired, and we focus a lot in our unit in Boston on the genetic causes, normosmic hypogonadotropic hypogonadism, or when it's associated with inability to smell, Kalman syndrome. There can also be combined pituitary hormone deficiencies resulting from mutations in genes that are important for anterior pituitary development. And the big distinction here from primary gonadal failure is the ability to restore fertility by administration of either gonadotropins or pulsatile GnRH. The last 2 decades have seen an explosion in the number of genes that have been implicated in hypogonadotropic hypogonadism. So between 1991 and 2018, 43 genes had been reported to be pathogenic. So as clinicians, it's often challenging to know what genetic testing should be performed when you have a patient with hypogonadotropic hypogonadism in your clinic. And this was one algorithm that incorporates the presence or absence of anosmia and whether the inheritance appears to be sporadic or familial. And this can guide the type of genetic testing that one might do. So for instance, if you had a patient where the mode of inheritance clearly appeared to be X-linked, then the gene of choice to test would be what was formerly called CAL1 and is now called anosmin-1. If the inheritance was consistent with a recessive mode, then the proconedicin family, ProK2 and ProKR2, would be, for instance, common genes to check. Sometimes there can be overlap. So this sort of distinction between absence of smell and normal sense of smell may be artificial. So that there are some genes, particularly those in the FGF pathway, that can be implicated in both Kalman syndrome and normognosmic hypogonadotropic hypogonadism. And finally, for those that have a normal sense of smell and a recessive mode of inheritance, we think of mutations in GnRH1 or its receptor, or KIS1 and its receptor. But it's also becoming clear that it may not be a simple monogenic disorder. And data from our group has shown that there is evidence of oligogenicity, so mutations in more than one gene within a kindred. And this can explain some of the phenotypic heterogeneity that we see. In terms of acquired causes, the one I wanted to focus on is the functional causes. So we're all very familiar with the impact of weight loss on the reproductive axis in women, but it hasn't received the same attention as in the male until relatively recently. And 2 years ago in JCM, we published a paper on functional hypogonadism in a group of young, healthy men who had symptoms of hypogonadism in the setting of excessive exercise. So they were typically exercising for more than 10 hours a week, or they lost more than 10% of their body weight. And they were brought into the Clinical Research Center for frequent blood sampling for LH. And some of them had an apulsatile pattern. So really you can see that there's no pulses of LH, which should normally be secreted every 2 hours. Others had this what we call sleep entrained pulse pattern. And that meant that the pulses that were present occurred during sleep, shown here in the bar, the hatched bar. And this is the type of pattern that we see typically at puberty. And then others appeared to have, for all intents and purposes, a normal pattern of LH secretion, yet all 3 subjects that are shown here had low testosterone levels. And I'm showing you an example of one patient who at baseline had a low testosterone, so 225 nanograms per deciliter. His BMI was within the normal range, but he was a very muscular individual with low body fat and low leptin levels. And you can see that when his weight increased, so his BMI went up to 27.9, the number of LH pulses went from 3 to 8, and his testosterone level went from 225 to 442. So this is an example where correction of an underlying abnormality rather than testosterone replacement is the optimal treatment for hypogonadism. I'm sure all of you are aware that in the decade between 2000 and 2010, there has been a marked increase, so about a 4-fold increase in testosterone prescribing. What's also striking is that the increase is largely within the United States, whereas our counterparts in the United Kingdom are much more conservative in their use of testosterone. And to try and understand the basis for this increase, it's important to appreciate some of the key dates in androgen prescribing practices. So testosterone was first isolated back in 1935, and for many decades, the only method of giving testosterone was a deep intramuscular injection of testosterone esters and N-theta cypionate. In 1997, the FDA approved direct-to-consumer advertising for prescription meds, including testosterone. And then in 2000, the first testosterone gel was approved. And that same year, the lay press really featured a number of articles on the purported benefits of testosterone in boosting sexual function and body composition. Whereas at the same time, in the more scientific literature, caution was being advised that the benefits attributed to testosterone were really not supported by clinical data at that time. And so when we think of the indications for androgen therapy, nobody would have any problem with using testosterone for men with classical hypogonadism. And that would be patients with conditions like Klinefelter Syndrome or Kalman syndrome. There's also a role for using testosterone in boys with delayed puberty because of the negative psychological consequences that can arise from lagging behind peers, and also to ensure that they achieve their peak bone mass. Our pediatric colleagues use testosterone briefly in boys with micropenis. But the areas of controversy are the use of testosterone in the aging male and the use of testosterone to treat hypogonadism that's associated with comorbidity, and that's mainly obesity and chronic disease. It may seem very obvious to say that there's really no indication to give testosterone to men with normal testosterone levels, but this is happening at many men's health clinics, certainly across the United States. And this is really supplementation as opposed to replacement. And while I mentioned in the introduction the classification into primary and secondary hypogonadism, aging is an example of a condition that can cause dual defects in the HPG axis. So at the level of the hypothalamus, there's a reduction in GnRH secretion with aging. And at the level of the testis, there's a decrease in Leydig cell number and responsiveness to LH. So the net effect of this is that total testosterone levels decline by almost 2% per year from the fourth decade. But unlike menopause, where estrogen levels inevitably decline significantly, for many men as they age, while testosterone levels may decline, they can remain within the normal range. And some of the best data on the prevalence of hypogonadism with aging come from the European Male Aging Study, led by Fred Wu, a large community-based study of men aged 40 to 80. And you can see that overall the prevalence is just 2%, so hardly an epidemic. That prevalence increases with age, it increases with increasing BMI, and it increases with additional comorbidities. And I think a useful statistic to have when counseling patients is that a 5 kilogram per meter squared in BMI is associated with a decline in testosterone that's comparable to about 10 years of aging. And while unfortunately there's nothing that we can do to reverse the aging process, there are certainly many ways at which we can address BMI, as we heard in the previous talk by Dr. Gill. So what are some of the challenges that we face in diagnosing hypogonadism? At the very basic level, there's still debate as to the threshold testosterone level to make the diagnosis, and if that threshold is the same for all target tissues. There's also considerable variability in testosterone due to circadian rhythms, medications, comorbidity, and assay methodology. And an important factor to remember is that about a third of men with low testosterone levels will have normal levels on repeat testing. And there's really a greater likelihood that comorbid illness is contributing to non-specific symptoms of hypogonadism in older men. So I mentioned that aging causes dual defects in the HPG axis. So can many other conditions, including hemochromatosis, alcoholism, glucocorticoid therapy. Kalman syndrome can have defects in the testis as well as the hypothalamus, and then adrenal hypoplasia congenita. So the European male aging study was very useful in trying to see what the predominant level of the defect in aging actually is. And so in this graph here, you can see 4 quartiles divided by testosterone and LH. And so in the European male aging study cohort, the vast majority, so about 3/4, had normal testosterone levels and normal LH, so they were eugonadal. The next most common was secondary hypogonadism, so about 12%. And then the third most was an entity that they described as compensated hypogonadism, where the testosterone level was maintained within the normal range, but only by increasing levels of LH, so analogous to compensated hypothyroidism. And then the smallest cohort had primary hypogonadism. Now, when they looked at the percentage of each of these categories across decades, they found that, as you'd expect, the fraction of eugonadal men decreased as you went from the 40 to 49-year-olds to those in the 70 to 79-year-old. But there was really no change in the prevalence of secondary hypogonadism with aging. What did increase as men got older was both primary and compensated hypogonadism. So when you see secondary hypogonadism in older men, it's usually the impact of the comorbid illnesses that they accumulate as they get older, as opposed to aging per se. And in the United States, the Food and Drug Administration, they published restrictions on the indications for testosterone use back in 2015, saying that these products are approved only for men who have low testosterone levels caused by certain medical conditions, and that the benefit and safety hasn't been established for the treatment of low testosterone levels due to aging. Most of the data that we have on the impact of testosterone in middle-aged and older men with no clear cause for their hypogonadism other than age comes from the testosterone trials, for which there was a nice review published by Peter Snyder in Endocrine Reviews. And the summary from these placebo-controlled trials of testosterone were that there were a number of benefits, so improvements in sexual function, bone density and strength, mood, and anemia. There was sort of disappointingly no effect on cognition or overall vitality. And then there was some negative effects, and that was an increase in the coronary artery plaque volume. There was no increase in cardiovascular or prostate adverse events, but this study was really not powered to assess this risk. And while bone density improved, there was no data on fractures. So how do we diagnose androgen deficiency in men? Well, the Endocrine Society put forward these clinical practice guidelines that were updated in 2018, recommending that the diagnosis be made when you've got consistent symptoms and signs and unequivocally low total testosterone levels. And the symptoms and signs really vary depending on what the age at presentation is. So in neonates, there can be clues to the presence of hypogonadism. If you see unilateral cryptorchidism, microphallus, and both of these conditions point to a problem in the 3rd trimester of pregnancy. In contrast, if you see hypospadias, where the urethra is opening up on the undersurface of the penis as opposed to the tip, that indicates a problem in the 1st trimester of pregnancy. More commonly, we diagnose hypogonadism when there's failure to develop secondary sexual characteristics, unicoidal proportions. One of the challenges when you see a 16-year-old who has not gone through puberty is to determine if this represents constitutional delay or true hypogonadotropic hypogonadism. Factors that can be helpful include a family history. Obviously, if there is sibling with Kalman syndrome, that makes that condition more likely. Short stature would favor constitutional delay. And the history may be helpful if there's history of anosmia, cryptorchidism, or microphallus. If there are anomalies on physical exam, like synkinesia, which is mirror movements, some midline defects like cleft lip or palate, or digital anomalies, all of those would favor congenital hypogonadotropic hypogonadism. But often the diagnosis could only be made with the passage of time. But more recently, there has been a new test that's helped to identify those boys who have pubertal delay to determine whether this is likely to be just delayed or permanent hypogonadism. And the test is the LH response to kisspeptin. And so they had a group of 16 girls and boys with no evidence of puberty. And if the LH response to kisspeptin was 0.8 or above, it identified those adolescents who would go on to enter puberty at a later stage. By contrast, if the LH response was less than 0.4, on follow-up, those boys and girls did not progress through puberty. So the LH response to kisspeptin was superior to the LH response to GnRH or inhibin in predicting the onset of puberty. In adult patients, hypogonadism can present with fatigue, changes in body composition, sexual function, and sometimes a metabolic phenotype. So the second component of the diagnosis is to demonstrate unequivocally low testosterone levels. And as you know, testosterone, there are different fractions we can measure. There is the total, which is everything in the circulation, both the free and protein bound. The free testosterone, which is just about 2%, which is not bound to SHBG or albumin. And then the bioavailable, which is a combination of the free and the albumin bound. And the recommendation is to measure testosterone in the morning because there is significant diurnal changes, although these become attenuated with age, and to use a reliable assay. In the recent iteration of the guidelines, there's also a recommendation to measure testosterone fasting. And this was based on data that we published showing that testosterone decreases significantly after an oral glucose load. And that in as many as 15% of men, testosterone levels which were normal at baseline fell to the hypogonadal range after glucose. And this was true in men who had normal, impaired, and diabetic glucose tolerance. Another important thing to remember when you're making the diagnosis is to always confirm it by repeated measurements, no matter how low the level is. And this was a young, healthy volunteer that came into our clinical research center. And you can see that he has pulses of LH sort of intermittently over that 24 hours. And he starts off with a testosterone level. So this was drawn from a pool over 6 hours. It's in the mid-normal range, as you would expect in a young, healthy male. But then after this long pause in LH secretion, his testosterone drops to 91. That then sends a strong signal to the hypothalamus and the pituitary to start secreting again. And this results in the testosterone levels being restored to the normal range. So if you were to pool the entire 24 hours, you would have a normal testosterone. But if you were to sample the patient just at this point, you could be misled into thinking that he had hypogonadotropic hypogonadism. If the total testosterone is low normal and altered SHBG levels are suspected, then it's important to measure the free or the bioavailable. And there are a number of factors that can influence SHBG. The factors that are particularly important for increasing it are age, anticonvulsants that are enzyme inducers, hyperthyroidism, HIV, and liver disease. And factors that decrease SHBG, in clinical practice, the most important ones are insulin. So in patients with obesity or type 2 diabetes, SHBG is low, and hypothyroidism. And when you're measuring free testosterone, the gold standard is equilibrium dialysis, but it's not always available in clinical labs because it's labor intensive and expensive. The next best option is to use a calculated free testosterone, which is calculated from measurements of total testosterone, SHBG, and albumin, and correlates strongly with the free testosterone measures by equilibrium dialysis. What is not recommended is to use the RIA for free testosterone. And increasingly, it's becoming recognized that free testosterone is probably the most biologically active form of testosterone. And these are, again, data from the European Male Aging Study. And what they did in this particular study was to stratify their population into 4 different groups, depending on what their total testosterone and calculated free testosterone levels were. So about 80% had normal total and normal calculated free T. And then if you look at the other 3 parameters, the low total testosterone and the low calculated free testosterone, you can see that about 10% of their population met these criteria. And these were the men who tended to have a lot of comorbidities and be obese. And they had some of the typical symptoms that you would associate with hypogonadism. When they looked at patients who had a low calculated free testosterone, but a normal total, they saw that same constellation of symptoms. So changes in body composition and sexual function and bone mass. But when they looked at the smaller group of patients who had a low total testosterone, but a normal calculated free testosterone, they did not see the same typical symptoms of hypogonadism. So no changes in bone density, they didn't see the sexual symptoms or the changes in energy. And so these data would suggest that if you have a low total but a normal free testosterone, that you may not benefit from testosterone replacement. So the typical algorithm then for diagnosing hypogonadism would be to get 2 morning total fasting testosterone levels. And then you want to classify the level of the defect. If gonadotropins are high, you obtain a karyotype. If they're low, then you need to exclude functional causes, including weight loss and medications. You want to make sure that the defect is limited to the gonadotropins. So you can do anterior pituitary testing and rule out hyperprolactinemia and hemochromatosis. And then the indications for pituitary imaging are a total testosterone of less than 150, elevated prolactin, the presence of other pituitary hormone deficiencies or neurological symptoms. Many times people will wonder, what is the cutoff testosterone for diagnosing hypogonadism? And if you have an assay that is harmonized to the CDC standard, then the lower limit of normal for healthy, non-obese young men is 264 nanograms per deciliter. So what do you do if you can't find a cause for low testosterone? And I would say, first of all, make sure that you have repeated morning fasting measurements and that you're using a reliable assay. Make sure that you performed a comprehensive evaluation that was not done during an acute illness. And then importantly, consider non-pharmacologic approaches. And chief among those is weight loss. And this shows the impact of weight loss, whether it's by simple diet and exercise in the open circles, or bariatric surgery in the closed circles. And you can see that there is a significant relationship between the percent of body weight that's lost and the increase in total testosterone that ensues. But it's also important to appreciate that there are differential effects of weight loss on total and free testosterone levels. So here you're looking at the percent weight change and the percent change in either total testosterone or free testosterone. And you can see that if you lose about 5% of your body weight, you will see a significant increase in total testosterone. But to see a significant increase in free testosterone, you have to lose about 15% of your body weight. So a much more significant degree of weight loss. So to conclude, I would say that the diagnosis of hypogonadism should only be made when the symptoms and signs are accompanied by consistently low testosterone levels measured by a reliable assay. Comprehensive evaluation should always be performed before initiating treatment. A low testosterone is not a diagnosis. The major increase in testosterone use in the past few decades has been in men with functional hypogonadism, which may be reversible without having to use testosterone replacement. The diagnosis of hypogonadism should be reviewed periodically because there is a potential for reversibility. And this is true even in patients that have genetic causes such as Kalman syndrome. The benefit-risk ratio of testosterone replacement in older men is still uncertain, particularly with regard to cardiovascular disease. And as physicians, I think we should go back to first principles and that motto of Hippocrates, primum non nocere, which is first, do no harm. And so to optimize the benefits and minimize the risks of testosterone replacement, it's important to have careful patient selection. In future, this may be informed by pharmacogenetics, to carefully monitor patients and make sure that testosterone levels are maintained within the normal range. And until we have a better idea of long-term safety, treatment should be discontinued if side effects develop, if symptoms do not improve, or if the inciting factor, whether that be obesity or opiate use, has resolved. So I'd like to thank you very much again for the invitation to speak at this conference. And I'm not sure if we have any time for questions, but I would be happy to take them if we do.
Thank you very much, Professor Francis, for this excellent review of this topic. Thank you very much.
Okay, my pleasure. Thank you again for the invitation.